Hello, and welcome to the introduction and overview sections for Chapter 5 through 8. I hope that you found the first 4 chapters in a bit of an abbreviated form, a nice overview, and I'm going to attempt to do the same for Chapters 5 through 8, which are more of the clinically relevant topics as they pertain to heart-lung interactions. So, a bit of an overview. In Chapter 1, we analyzed the relationship between intrathoracic pressure, or pleural pressure, which I use interchangeably in my talks, and thoracic volume as a function of the static and dynamic properties of the lungs and chest wall. And we did this using the Campbell diagram as a graphical analysis. Then in Chapter 2, we studied the determinants of cardiac filling, that is the right atrial pressure, and how that's determined simultaneously by the venous return and cardiac function curves, and for that we used the Guyton diagram. In Chapters 3 and 4, we joined these graphical graphical illustrations of the Campbell and Guyton analyses into a single depiction of heart-lung interaction, which I think is a nice and novel way of considering heart-lung interaction, especially as it applies to the intensive care unit. And then with this knowledge base, in Chapters 5 through 8, we're going to consider more clinically relevant topics of with our newfound cardiovascular and respiratory physiology knowledge. So in Chapter 5, I talk about the physiology of extubation failure. We've all been in this situation where we're fairly sure a patient's going to fly. We pull the tube and then they just sort of seem to spiral out of control. And I want to talk about some of the mechanisms as to why that may occur, as we so-called liberation from mechanical ventilation. So all the effects that I talk about in Chapter 5 are much more prominent in patients with little physiologic reserve. So this is your patient with an FEV1 of less than a liter and an ejection fraction of less than 20% who has been intubated for whatever reason, and now you're going to attempt to extubate. Their numbers on the ventilator may look deceptively good, and then things may change abruptly when you remove positive pressure. And I want to emphasize that in this Chapter 5, not all of the effects that I talk about are at play. This isn't what's occurring in every patient who you're extubating. This is just to give you a sense of potential mechanisms. And more importantly, I want to highlight how respiratory load, that is abnormalities of airways resistance and thoracic compliance, and especially pulmonary compliance, which are essentially how we analyze the pulmonary determinants of physiology on the Campbell analysis, and how that can feed back and impose stress upon both ventricles and can kind of cause the so-called vicious cycle. And then, as we will see, compromised biventricular function can then feed back and worsen the respiratory load. So this is your heart and your lung. You may have seen this in my lectures already. So when you remove a patient from positive end expiratory pressure and airway pressure, you immediately get an increase in airways resistance. And that's firstly from the act of simply removing positive airway pressure, which tends to stent open the airways. But also, and again, in patients with pretty significant COPD, especially emphysema where there's loss of elastic recoil, you can get this phenomenon of dynamic collapse as the patient begins breathing rapidly. And I illustrate dynamic collapse using this cartoon of a generic alveolus airway, and this is your thorax. And this yellow highlighted area represents cartilaginous tissue. So let's say, and these numbers are completely made up, that this is a normal patient with an elastic recoil pressure of this fictitious number 2. Well, this patient, say, on their Campbell analysis is normal, and they've started FRC, and they've taken a deep breath in, and they've inspired, and now they're up here. And they're just about to perform a forced expiration, which they then do there. So now their intrathoracic pressure is much higher as they're forcing out a breath. So let's say that forced out expiration generates a wildly high pleural pressure of this fictitious number 4. Well, then the driving pressure at the initiation of this expiration becomes the summation of your pleural pressure and your elastic recoil pressure. That's sort of like how bad the lungs want to stretch back and how bad that you're pushing the lungs inward as a function of this increased pleural pressure. So then at the initiation of exhalation, the alveolar pressure is 6, and it creates a gradient down the airway. But in this patient, the pleural pressure is 4. That doesn't supersede your airway pressure until this portion of the airway that is closer to the mouth. And this portion of the airway is protected by cartilaginous structures. So you can see that, or what I'm trying to graphically represent here, is that there's minimal, if any, collapse, and forced expiration proceeds. In the patient with dynamic airways collapse as a result of emphysema, let's say their elastic recoil pressure is cut in half. So instead of fictional 2, it's now fictional 1. Well, this patient is breathing at high lung volumes because they're emphysematous and they're trying to maximize airways resistance, because if you breathe at high lung volumes, you tether open airways. So this patient has now taken a deep breath in at this high lung volume, so their intrathoracic pressure, they're breathing spontaneously, is quite negative. And then they force out an expired volume, and it increases their intrathoracic pressure as they forcibly breathe out. Well, now their driving pressure is less, and the decrease in the driving pressure is driven in this example by a halving of their elastic recoil pressure. So now you can see that the gradient down the airways is diminished, and now this pleural pressure that, for argument's sake, we're saying is the same in this emphysematous patient as it was in the normal patient, well, that's now in an area that is closer to the alveolus, where it doesn't have the protection of the cartilaginous airway structures, and you get dynamic airways collapse. And what this is doing is this is in particular increasing expiratory airflow resistance, and these patients can very quickly begin to air trap, which has a whole host of hemodynamic consequences. So again, just going back to the Campbell analysis, this is, say, a patient breathing normally, but then as you increase airways resistance for whatever reason, increase, say it's an asthma exacerbation or a COPD exacerbation, the patient, as I mentioned, tends to breathe at higher lung volumes, and what that does is it lowers airways resistance as you tether open the airways, and this promotes both inspiratory flow and especially expiratory airflow. In this patient, you can see that FRC becomes dynamically determined, and it follows the chest wall elastance curve, because as the lungs becomes hyperinflated and push out against the chest wall, the pressure that is generated between them, the intrathoracic or pleural pressure that is generated as a result, follows the elastance curve. And what this does is it leads to auto-PEEP, which increases the inspiratory threshold load, and that's this pink dotted line here, which you can see between your FRC and the intrathoracic pressure at which airflow begins to occur. So this is the threshold load, and this is essentially equal to the increase in end expiratory alveolar pressure from auto-PEEP and dynamic hyperinflation, or dynamic hyperinflation leading to auto-PEEP. So this patient must now then generate this additional decrease in intrathoracic pressure to initiate airflow. So this hyperinflation and auto-PEEP, as you can imagine, decreases your thoracic compliance. And as we saw, when you're breathing at very high lung volumes, the compliance curve of the lungs and the chest wall become worse, and therefore a greater change in intrathoracic pressure must be generated to drive a volume in airflow. So the increased airways resistance and the decreased chest wall compliance and thoracic compliance leads to, this is not abbreviated very well, but an increased maximal inspiratory pressure. So essentially what it really leads to is lower pleural pressures during inspiration and higher pleural pressures during expiration. So you get this variable change, dramatic wide swings in inspiratory and expiratory pressure. And this drives up your work of breathing. The hyperinflation and auto PEEP in and of itself provides or establishes an increased load against which the right ventricle must eject. And in addition to that, the low intrathoracic pressures also loads the right ventricle for somewhat complicated and somewhat controversial mechanisms. Simply lowering intrathoracic pressure in and of itself also tends to, we think, stress the right ventricle as it does for the left ventricle. And the reason this is because of the physiology that was first delineated by Saul Permut in the early 60s, and that is there's two populations of blood vessels in the lungs. There's the alveolar and extra-alveolar blood vessels. And the vascular resistance of the extra-alveolar blood vessels decrease with lung volume as they are tethered open. But the vascular resistance of the intra-alveolar vessels, the blood, essentially the capillaries and the blood vessels just pre and post capillary, tend to increase with increasing transpulmonary pressure as they're collapsed. So you get this, your best pulmonary vascular resistance on the y-axis here lands at just about FRC. And so if you begin to air trap and become dynamically hyperinflated, you begin moving in this direction and your total vascular resistance goes up as reflected by this green curve. This increase in afterload and actually increasing or lowering your intrathoracic pressure during an exacerbation of airways disease forms the perfect milieu for an increased right ventricular volume. And the reason the right ventricular volume increases is because the right ventricular transmural pressure increases. So if this patient is breathing on this Campbell analysis by dragging their intrathoracic pressure downwards along this increased dynamic airways resistance curve, well, the right ventricular cardiac function curve shifts relative to the venous return curve. The curve shifts downwards because of the increase in right ventricular afterload. You do have some changes in your venous return curve, as I've illustrated here. I'm not going to get into the reasons why the venous return behaves this, or the venous return curve behaves this way. But now you have this low intrathoracic pressure, but you can see that the distending pressure of the right ventricle is increased dramatically, and that this is the CVP, or the right atrial pressure, that you might be measuring with a triple lumen catheter, while it is a subatmospheric level. Again, this is right atrial pressure on the x-axis, and this point here marks 0, so this is subatmospheric and this is above atmospheric pressure. While you may be measuring a pressure that is subatmospheric, the intrathoracic pressure you do not know is quite low, and so the distending pressure between the two is quite high. And this distending pressure increases right ventricular volume. Well, that's, let's call that right ventricular distension, the D. What does that do? Well, via ventricular diastolic ventricular interdependence, it then leads to left ventricular, we'll call this D, dysfunction. It impairs left ventricular output. And what happens is the negative pleural pressure that's generated during inspiration also afterloads the left ventricle, which I talk more about in Chapter 5, and that further impairs left ventricular function. So you've got a couple things working against your left ventricle here. One is that it's being impinged upon by the right ventricle, and it's also having a harder time ejecting because of these wildly negative inspiratory intrathoracic pressure. The hyperinflation and auto PEEP, before moving on, also tend to squeeze the heart like a hand from the outside because of lower lobe gas trapping. And what that does is it tends to actually facilitate this physiology of ventricular interdependence, because the elastance of the right ventricular and left ventricular free walls increase. That is, their compliance decrease. So it tends to promote ventricular interdependence during diastole. It also tends to raise your CVP and your pulmonary artery occlusion pressure, but not because the filling pressure of the ventricles are increasing, but because there is a higher intrathoracic pressure that's being transmitted to the vascular space. So this is a cartoon of hemodynamics and PEEP. Auto PEEP and dynamic hyperinflation tend to collapse alveolar capillaries, which are these glowing alveoli down here. So they shrink, and the lower lobe gas trapping near the heart tends to compress it and raise pericardial pressure. So you'll see that the pressure will start to increase, the intrathoracic pressure will increase on this Campbell diagram here, and the heart size will shrink. And this is why you see these little teardrop-shaped hearts in emphysematous patients. And that tends to hinder venous return. But during a big inspiratory effort, there may be very negative pleural pressures, which then tends to augment venous return. And overall, in patients with COPD exacerbations, there tends to be a net increase in venous return. And again, this lecture is really focusing on the classic mechanical interactions between the heart and the lungs, and it's sort of neglecting the fact that in a patient being subjected to this physiology that we've talked about, they're going to have a dramatic adrenergic response, and then the adrenergic system is also going to affect the cardiopulmonary reserve. It will tend to increase venous return, tend to preload the heart. It'll increase myocardial oxygen requirements, and this will also be working against this patient. So all of this we just talked about, this is kind of what happens in obstructed lung physiology, or if a patient with bad emphysema who, because of the removal of positive airway pressure, their work of breathing goes way up and they begin gas trapping. So this left ventricular dysfunction, as we've talked about, increases the left atrial pressure. And what that does is it, as you can imagine, promotes the formation of interstitial and alveolar edema, which then feeds back and completes this vicious cycle of increased respiratory load by both decreasing thoracic compliance and increasing airways resistance. So the formation of alveolar edema has been shown to occur in an all or none or quantal phenomenon, and that is the alveolus is either full of fluid or it's not. And what this edema does is it significantly reduces the radius of the alveolus and also impairs surfactant activity. So by a simple mathematical relationship, if you assume that the alveolus volume is that of a sphere as 4/3 pi r to the third, and that pressure by the law of Laplace of the sphere is two times the tension on the alveolar, or in the alveolar cells, I guess in this situation it would be the tension on the type 1 pneumocytes, divided by the radius of the alveolus, then you can kind of plug it into the compliance equation, which is change in volume and change in pressure. And then compliance becomes 2 pi r to the fourth, so it becomes very, very sensitive to changes in radius, and also somewhat sensitive to changes in tension. And the tension will be driven by impaired surfactant activity, while the decrease in radius will be impaired by alveolar bubble froth. So decreasing the radius and increasing the wall tension will both serve to dramatically reduce your pulmonary compliance, and this has been shown in humans, actually in literature dating back to the 1950s. And then how does it increase airways resistance? Well, if this is a cartoon of your bronchovascular bundle in the lung, and this is the bronchial and this is a pulmonary arterial, and there's a potential interstitial space between them. When you get increased lung water, the initial response is to drain the excess water from around the alveoli up through the alveolar interstitium and then through the bronchovascular bundle via the lymphatics. And it does this because of it's sort of like a sump function. The pleural pressure around the interstitial pressure around the bronchovascular bundle as they approach the hilum becomes more affected by pleural pressure. So there tends to be a lower pressure in the bronchovascular bundles as compared to the alveolar pressure, and so it promotes a nice gradient for lymphatic drainage. But what happens is that lymphatic drainage builds up, and this, you can actually see this under freeze fracture microscopy, that both the arterioles and the airways can become compressed by this interstitial edema, and this is the etiology of the so-called cardiac wheeze, which clearly increases airways resistance, which is a further load on the respiratory system. And then by that diagram, which we showed you a couple of slides ago, you can see how things can very quickly spiral out of control.